My name is Andrea. Very excited to be here with you. PMD Alliance is committed to bringing quality education and having it be really informed by what questions do you all have. So, many of you might have taken part in our pre-program survey. So what we're going to talk about is really tailored to exactly what questions you all have. So today's presentation, we are recording it, so you'll be able to access the recording, share it with loved ones, rewatch it again if there's something complicated that you want to hear over. So give us a couple days for us to get it cleaned up, and then it'll be on our website and on our YouTube. We also want to make sure today's session, if you have comments, if you have questions as we go through the material, our chat will be live. So I invite everyone to give it a practice go. Put in the chat where you're tuning in from. Where are you in the US or maybe the world? Is it a beautiful spring day where you're sitting? Always love to hear and connect with folks across the power of Zoom. Okay, well, Scott is in Redmond, Washington. Good to see you. And Catherine's in Chicago. Okay, well, the chat's working. We have the recording going. And if anyone has AV issues, if you can't, if your video's being fussy or you can't hear, my colleague Carrie here, wave Carrie, there she is. Just put a note in that chat, and Carrie will send you a DM, do some troubleshooting, walk you through some of the things. Most of the time, we can make a dent in AV fixes. All right, so we have a recording, talked about troubleshooting, and it looks like the chat is active. So good to see people from all over tuning in. Well, let me now take the chance to introduce you to our guest presenters today. So we have two physician experts joining us. So first off, we have Dr. Scott Sorensen. He's currently an ophthalmology resident in San Francisco. So those of you, I saw a few people in the Bay Area. He's down the road, and he's going to be pursuing a fellowship in neuro-ophthalmology at the University of Washington. I think I saw some Seattle folks in the chat as well. And also joining us today is Dr. Shahnaz Miri. And I know more about Dr. Miri because we've worked together throughout your career. So let me tell you guys about Dr. Miri. She is a fellowship trained movement disorder specialist, and she did her residency and fellowship at Georgetown. She then went on to pursue further education in neuro-ophthalmology. So she's right now serving as a clinical instructor at the University of Miami, and has a focus, has a background in information technology. She's very interested in developing digital biomarkers and creating innovative health IT solutions to help with patient engagement and improving care access for movement disorder patients and their families. A very smart physician and very smart researcher, and we're so excited to have her here. Many of you, raise your hand or put in the chat. Did some of you take part in the AI-powered survey to send in your questions ahead of time? I see some nods and some waves. So thank you all for doing that. Like I was saying, it allows us to customize what we're going to talk about today. But even if you didn't have a chance to send those in, still have the opportunity to ask questions and engage. So, without further ado, hopefully, Dr. Miri, that gave you a chance to get your slides ready. But in addition to my introduction, I want to give you the floor and see if there's anything else that you wanted to share about your background and your research and your clinical work.
Thank you so much. It's a pleasure meeting you all, and it's great to joining you all today. And I just wanted to correct that I'm currently not faculty at University of Miami, and I'm working in my practice in San Francisco.
Oh,
And
sorry about that. I had the
no
old bio.
problem, no problem. Thank you so much.
Okay, so we could see your screen. Looks great.
Great. So great to great meeting you all, and thank you so much for participating in this pre-webinar survey, so that this allows us to just present based on what are the most common questions that you asked us about vision in Parkinson. Um, okay, great. Let me- hold on. All right, great. So about vision in Parkinson, first of all, why this topic matters? Because it's an important topic because it can affect multiple factors and multiple like daily life in patients with Parkinson. It can cause like there are multiple different issues in patients with Parkinson, vision problem, including reading difficulty, using a screen, difficulty with depth perception. It is very important. Vision is very important for balance, walking, going up stairs or down stairs, important for driving, safety, as well as comfort. So we'll discuss everything that relates to this. Um, so based on your question, we shaped this webinar with most common concern in Parkinson disease and also some of your questions. So one of the most common concern was difficulty focusing, double vision, dry eye, blurred vision, difficulty reading, difficulty with depth perception, as well as a few other questions that we will go over. And then today we are going to discuss that, first of all, are these problems all caused by Parkinson, or are these like coexisting with Parkinson, or which ones are like more specifically related to Parkinson? And also we'll go over the symptoms, questions that you discussed, and some practical next step. So about how Parkinson can affect vision. So first of all, Parkinson, as it affects like all the body movement, like in patients, it also can affect the eye movement, the blink rate, the eyelid movement. So with that mechanism can cause difficulty focusing and eye muscle coordination, and therefore it can potentially cause reading difficulty. It also reduces blinking rate, and then it can contribute to dry eyes, irritation, and also fluctuating blurred vision. Other than that, it also can affect visual processing, because visual processing from the retina, back of the eye, all the way to the back of the brain, which is the visual processing center, works with dopamine. So all these neurons in this pathway work with dopamine, and therefore low dopamine can affect the visual processing. And there are other common eye conditions that just come with aging, such as cataract, glaucoma, other retinal problem that are not necessarily related to Parkinson directly, but those are some of the other conditions that we encounter and patients with Parkinson encounter, and they should be just aware of it that those are just probably coexisting conditions and need evaluation separately. Um, so again, this is another slide separating some of the age-related eye disease and overall eye disease that can happen with, from the retinal macular degeneration that causes wavy distorted vision to glaucoma. That is an optic nerve problem, eye pressure problem that can cause like optic nerve thinning and visual field defect, as well as cataract that can cause cloudy, blurry vision, night vision problem. That are just general conditions that can like coexist, and patients with Parkinson can experience this similar to any other patient. And then, as we discussed, there are other conditions that are seen more common in patients with Parkinson compared to other, age-related, like same age population. So in the webinar, and sorry, in the pre-webinar survey that we had, as of yesterday, there were 51 people who called and participated in the survey, and I thank you for your time and providing this information so that we can have this insight. There were a few other calls that we looked at it. The result is not here, but we looked at the questions, and we'll discuss that all the detailed question later. Um, and um, and then 98% of people who called said that they are regularly seeing eye doctors, which is impressive. And about 30% had a known like eye conditions such as, glaucoma or macular degeneration, or had like any prior surgery such as cataract surgery. 88% of participants wear glasses or contact lens, and 67% of participants using progressive or multifocal lenses, glasses, that we will further discuss. And these are like the list of, I don't know if the size of the font is large enough, but among like all the prevalent symptoms that you mentioned, 90% of people participated in survey are having difficulty with focusing, eye straining, overall eye straining, difficulty with focusing, difficulty with reading has been one of the top complaint among you. And then dry eye was also very common. 76% had dry eyes, light sensitivity, and difficulty with depth perception. And as a result of perhaps dry eyes, some people 65% experiencing eye pain and burning sensation. So this definitely needs to be addressed. And then a balance problem, 63% mentioned that they have difficulty with balance, as well as, or I would say vision problem has affected them in terms of affecting their balance. And 61% had difficulty with double vision. And double vision, by double vision, we mean if you see two images side by side, up and down, or diagonally, and then if you cover one eye, double vision can go away. But again, binocular double vision that is more, pertinent to this talk is when you cover one eye, double vision goes away. That means that is from the eye muscle, an alignment of the two eye together. That is, if there is a misalignment, that's causing double vision. And then eyelid twitching, not as much reported. Visual hallucination, actually, this question was if you see any flashes of light, any phenomena, any colorful or shaped images, or human, animal, or other things that other people do not see. So I would say probably it's not 35%, is less than that. But I would say visual phenomena was reported by 35% of you. So we'll go over the top commonly reported problems. Again, dry eyes, difficulty with reading and focusing, difficulty with depth perception, and double vision. So many of you have been using reading glasses and you wonder why it still doesn't work. And you had updated prescription and still you had problem with reading. And I'm sure that that's very important to you, to many of you. So reading and blurred vision has a wide variety of causes, difficulty with reading and then blurred vision. So one of them is uh, age-related, aging of the eye that we call it presbyopia, meaning, you need more kind of lens and magnification to be able to see. But other than that, loss of contrast, meaning like the differentiation between the sharpness of the letters in a background that is kind of dim light background, that is something that is impaired in patients with Parkinson. And again, that's part of the visual processing that the dopamine is involved. And again, other conditions also can experience this, but uh, decreased loss of contrast sensitivity is known based on studies in Parkinson patients. That is more common in other in among other populations. Uh, so. So with that, with lots of contrast, text may look washed out or faded, and then especially in dim light, so you would need like additional lighting. Also, sometimes if you experience fluctuating blurred vision that you have to blink multiple times to be able to like make it more clear. So that can be related to the surface of the eye and dryness of the eye and tear film. And again, that part is related to decreased blink rate in patients with Parkinson disease. So these are two reasons that, despite having perfect glass, you still cannot read properly. So I would recommend, other than lighting the room, you have to get one of these like study lights that are kind of, you put it like, you can probably buy it from Amazon or online, that you just put the little study light over your book or whatever you're reading so that it gives you more contrast automatically and improve your vision. Plus dry eye care that Dr. Sorensen will later talk about it. That's another factor to help that fluctuating blurred vision and maximizing the light, as we said. Um, and also, most people using progressive lenses or multifocal lenses or, these bifocal lenses for reading. And I would say that that's not optimal. I would recommend to everyone that if you're using this and still having difficulty reading, it's just because those glasses are not perfectly fit for up close reading, especially for patients with Parkinson that already have depth perception problem and convergence insufficiency problem. So I would recommend a single reading glasses or single computer glasses if you work with computer more. That for sure can help a little bit more. Um, and then again here, you see the typical blink rate in general population is 16 to 18 times per minute, but in Parkinson disease, blink rate is much slower. And again, when you don't blink as much, the surface of your eyes get dry. And again, that's how the surface of the eye gets irritated and dry. That can be just one of the reason, okay? So it can be a painful, dry, blurred, that's another thing that should be addressed. All right, perfect. Um, so Dr. Sorensen, would you like to just talk about a little bit of dry eye in Parkinson?
Absolutely. I have some slides here that I can share. Thanks, Dr. Mary, for inviting me to join this webinar, and thanks to PMD Alliance for hosting it. This is great to see so many people on here. I'm going to share my slides, and then hopefully those are visible to everybody now. So, dry eyes and dry eye disease, it's probably the most common thing that I see in my clinic day to day. I see patients with this every single day, multiple times a day. It's extremely common. in any patient population. And as we'll talk about, and as we've been talking about, Parkinson's gives some extra reasons for the eyes to be dry, but this is really a very common thing for anybody. It's a huge industry, dry eye disease, and treating it. I always remember Ben Stein was famous for his commercials for Clear Eyes, but many celebrity endorsements are always in the ethos about dry eye disease. And even though it's very common, it can be very tricky to diagnose exactly why a specific patient has such dry eyes, and it can be difficult to treat. Part of this is because it's such a multifaceted system. I like to tell patients it's kind of a miracle that your eyes aren't dry all the time because your eyes are constantly open and they're constantly exposed to the environment. The wind, dust, all sorts of things are irritating them. Imagine if you walked around with your mouth open all day long, your mouth would get dry and it would get uncomfortable and you'd have to take sips of water. Well, the mouth has the benefit of being able to close and is closed most of the day, but your eyes are constantly open. And so it's just sort of a miracle of evolution, the system that the eyes have developed to keep the eyes lubricated pretty well most of the time for most patients. But it's a very multifactorial system with many subparts. The tear film itself, the actual liquid that sits on your eye, has at least three different components. If any one of those is defective or lacking or insufficient in quality or quantity, you're going to have symptoms. You need good eyelids that oppose to your eyes well. You need a healthy blink rate. You need a healthy eyelid surface. You need good drainage of the tears, which is a whole other system. And even if all of these things are perfect, there can be environmental factors, there can be systemic disease, and many, many other reasons why your eyes might feel dry. Dry eyes can manifest in many different ways, physical irritation, they can burn, itch, water, tear. You can have double vision. Sometimes patients will just say, my eyes feel tired very quickly or fatigued very quickly, and it can cause fluctuating vision, as Dr. Miri described. So you sit down and my vision is good for a few minutes, but after a while, things start to get blurry. All of these are just some of the ways that patients will describe dry eyes. Now, uh, everything I've said so far goes for every single patient that I see, but in Parkinson's, there are additional reasons why your eyes might be dry. And the biggest one here, as Dr. Mary has mentioned already, is that there's a decreased blink rate. So on average, you're blinking around 20 times a day, but there are activities and there are diseases like Parkinson's, which can reduce that blink rate down into the single digits. But also, if you just sit down to read a book or watch TV or do anything where you're really focusing with your eyes with intent, that by itself also causes your brain to stop sending the signal for you to blink as much. So if you're going to sit down and read a book, naturally you're not going to blink as much and you're going to dry out from that. Now, there are lots of treatment options for dry eyes. These target different ways in which your eye might become dry. And again, there's multiple, literally dozens, if not hundreds of treatments for dry eyes. But the simple things tend to work pretty well. And so these are the things that most patients would benefit from trialing at the start. One is just making sure that you're staying well hydrated. If the air around you is dry, a humidifier can work really well. And if you sleep with a fan on the face, that can dry your eye out overnight, especially some patients don't close their eyes fully when they sleep, and that can be really irritating, especially when you wake up. Another thing we tell patients is about this 20-20-20 rule. So if you're doing any sort of prolonged computer work, reading, watching TV, anything up close where the eye is just kind of open and focused, try to take a break every 20 minutes and for 20 seconds, look off in the distance about 20 feet away, let all those eye muscles relax, get a few good blinks in, blink, 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 and then go back to whatever you were doing. If you want to start doing things actually, physically intervening and putting something into the eye, artificial tears work really well. This is an over-the-counter remedy. If you go to your local drugstore, there's probably a whole shelf of artificial tears. It's kind of like flavors of ice cream. Just try a few until you find the one that you like. Most of them are very safe. Most of them work well. The downside is you kind of have a part-time job of putting tears into your eyes, is how some patients feel about it. Warm compresses or a heat mask can work really well to help your eye's natural glands, which reside in the eyelids, to work better. When those glands work well, they secrete a nice oil layer onto the eye, which is kind of like your eye's natural lotion and keeps everything moist and helps you retain the moisture on your eye. Fish oil or omega-3 supplementation can theoretically also help by giving you a healthier oil layer. And then beyond that, there's all sorts of things. One things that really helps some patients is punctal plugs, where your doctor can actually put a tiny little plug into the drain of your eye, and that, you know, kind of like plugging up your bathtub sink or your bathroom sink, it's going to keep more of that liquid in the sink or on the eye rather than running down the drain. So these are just some basic things that I tell my patients on maybe a first visit where I'm diagnosing them with dry eye. If your symptoms persist or are severe, after trying these things, there's a whole host of other things that you can do, but this is a really good place to start. And then I'll pass it back to Dr. Miri here. Thanks so much for your time.
Okay, great. Thank you so much, Dr. Sorensen. Perfect. All right. Perfect. So, as Dr. Sorensen mentioned, so dry eyes is one reason for this like difficulty with reading, and that was one of your your most complaint. But the other thing that can affect your vision and your reading is double vision. Now, to be clear, double vision by itself, again, when you see two images of one object in front of you, and that being said, like two images or overshadowing images, when you read up close, or just again, or sometimes people experience that at far distance. So double vision always needs further evaluation. And again, you have to cover one eye. And if you see the double vision goes away, that means that it's just from the eye muscles and eye alignment, and that needs evaluation by an eye doctor. Obviously, the best is neuro-ophthalmologist for evaluation of double vision, but you can start with an optometrist or regular ophthalmologist in your area. Um, but as you can see, among you, about 61% reported that they have double vision, and and the most common, like about 50%, mentioned that this double vision is up close, more noticeable up close when reading or when looking at the phone. And that is, again, I cannot do 100% diagnosis here, but when you have difficulty with focusing up close and maybe some overshadowing of the letter, that is more consistent with convergence insufficiency, but obviously, that needs further evaluation, but that can be just, one of the possibilities. And and again, this slide talks about, I'll come back to that convergence insufficiency, but this slide talks about 82% of patients with Parkinson disease overall in population experience some sort of visual problem, while 48% of age-matched control, healthy people do not experience that. So definitely visual complaint, eye-related problems are more common in Parkinson patients. And then, so now about the convergence insufficiency is just inability to pull your eyes inward together to be able to see something, focus on something up close. So That is more common. We cannot per se say that is caused by Parkinson, but we can say that there are many other conditions that also are associated with convergence insufficiency, such as traumatic head injuries. Some people who have head trauma, they have a high rate of experiencing this convergence insufficiency. But also in Parkinson patients, the eye movement and convergence of the eyes are affected. That is likely related to dopaminergic pathway in the brainstem. That the eye muscles kind of lose that flexibility to converge, and Parkinson patients just have a slower eye movement tracking and like kind of fragmented tracking of the lines up close just because of that misalignment up close. And again, one of you asked, my doctor said that this is not related to Parkinson disease. I believe your doctor meant that they kind pinpoint and say, this is Parkinson disease causing this. But again, it's just the association. It is more like in patients with Parkinson have a high rate of experiencing this convergence problem. And again, as we said, on top of everything else that we discussed so far, dry eyes, the glasses, single focus reading glasses, those are all helpful. But on top of that, some people will need prism because they cannot converge. They may see letters overshadowing or even double, and some people often close one eye to be able to focus and get rid of that double vision. And again, in this case, sometimes prism glasses embedded to your reading glasses can help to do the job for instead of like your eye muscle pushing too much, which also causes eye straining because you are constantly trying to push to see single image. Literally, prism glasses does that for you and improve the point of focus. So I would say that again, anyone with double vision should see an eye doctor, an optometrist or ophthalmologist to start and to just investigate thoroughly to make sure what's the reason for this double vision, because it can be a number of different conditions. We don't blame everything on convergence insufficiency, thyroid eye disease, any kind of nerve problem, like in any kind of patient can cause double vision. But again, we are talking about more a kind of double vision that only happens up close when you're trying to read. And that requires prism measurement and added on prism to your glasses. And one of you asked that I used prism glasses, but it's still that doesn't work. And again, maybe that's because we have a number of different issues as we discussed. Maybe again, what kind of glasses you use, single vision reading glasses, plus taking care of the surface dryness of the eye, plus the magnification lens should be perfect, and also some people may have other conditions such as macular degeneration, optic nerve problem related to glaucoma that by itself will kind of reduces the vision clarity or causes some visual field defect that will affect the reading. So that's probably another cause. And also people who have cataract, and cataract, as we discussed, is an age-related, kind of cloudiness of the natural lens inside the eye, and doesn't necessarily need surgery immediately. But again, people with cataract, they have difficulty with the vision and contrast as well, and they will need more light for reading to be able to read clearly compared to other people who do not have cataract or have done cataract surgery. And again, not everyone needs cataract surgery, so your doctor will decide about that. But these are a number of different reasons that will cause, difficulty with reading, and prism may not work. And Dr. Sorenson discussed dry eye issue, and also depth perception problem is another issue. Again, partly can be related to the eye muscles being able to, coordinate with each other, one eye with the other eye, to be able to see different objects at different distance. That's again, those kind of smooth eye movement, tracking is impaired in patients with Parkinson, or is slower. And then other than that, there is also the contrast problem, especially in dimmer light. Probably you wouldn't be able to clearly see the edges. And again, that can be another reason for difficulty navigating a stair on top of already existing balance problem with Parkinson. So that's important. And one of my advice always to my patient is, if you are using multifocal or progressive glasses, that can be an added on reason for your depth perception problem and depth judgment problem. Because, and as you saw, like about 60, over 60% of you actually are using progressive glasses currently. Again, progressive glasses are good. Maybe you have used them, those kind of glasses, for your whole life. But again, at some point, it just kind of is an added reason for difficulty with depth perception and judgment, because the upper part of the progressive lens will see the far distance and the lower part sees up close. So there is a different kind of depth. It causes by itself a different kind of depth perception problem. And if you are looking down, then that shows like up close, and looking down with a progressive lens will cause like more blurriness. So you probably will have more difficulty judging the distance when you're looking down. And again, that's why I would recommend you can still keep your progressive glasses, maybe for watching TV and reading something up close. But but for walking around, I always recommend the single distance glasses when you go out to walk, or in your day-to-day activity. If you're not reading, then just use one single distance glasses, because that can at least help a little bit with the depth perception. And hopefully that will reduce the fall risk. So again, it is very important to first for you to recognize, and I'm sure that you have all this complaint, but you may not know which one to bring up. But again, like I said, the double vision, you definitely should bring it up to your, starting from your regular eye doctor, optometrist, ophthalmologist, and they can initiate referral to neuro-ophthalmologist or neuro-optometrist, or someone, even some optometrists or eye doctors, they prescribe prism. So I'm sure your local doctor would know who would evaluate the double vision and prescribe prism. And in some cases, they may need more workup. They may get an MRI to just get an image of the eye muscles or the nerves, just to make sure, they confirm the diagnosis. But I would say you definitely should bring that up. And again, Dr. Sorenson discussed about the dry eye and soreness of the eye, the painfulness in the surface of the eye, that are all from one cluster. And again, you should bring that up, and there are treatment options that can help you. So again, if we want to categorize here and triage, so the the conditions that probably are associated with Parkinson are treated and are treatable: reading, double vision as a result of convergence insufficiency, dry eyes, eye discomfort. Uh, Sometimes even Parkinson patients may experience fluctuating blurred vision that can be again related to dopaminergic pathway and retina processing, and your medication dosage. There is not much to do about that, but just being aware of that. And also visual hallucinations. So visual hallucinations, I had personally many patients that were experiencing visual hallucination, but not talking about it unless a movement disorder specialist ask them to, do you experience visual hallucinations? Visual hallucinations, formed visual hallucinations, if you see something that doesn't exist, people sometimes see animal, cat, ants, and things like that, like around, or people in the environment, which are again, to most people are not as scary and they don't talk about it, but is kind of from the visual processing abnormality is not well understood, but based on PET scan data, the vision center in the brain, the occipital lobe, that doesn't function as well, and the neurons in that area are affected by Parkinson. So that said, those are also treatable. There are medications to improve that, and there are medications that can improve improve those visual hallucinations. So you definitely should bring it up with your doctor if you haven't. And again, normal aging, we discussed cataract, glaucoma, macular degeneration. And the red flags are if you have any sudden new changes in vision, if you wake up one day, and again, those are not related to Parkinson. I'm just saying those are urgent things that obviously anyone would seek attention. If like there is sudden onset flashes of light and like seeing some, curtain coming down or some major part of your visual field is missing, sudden vision loss, that's something that you definitely should seek urgent attention. Another question that was brought up about, some colorful visual phenomena that one of the callers reported that, waking up, sometimes experiencing colorful lights in some part of the field of vision that would last for example about 15 minutes, and then after that completely resolves. So my suspicion is that might be something like visual aura or migraine aura, because patients with migraine headache, they experience some sort of zigzag line, colorful rainbow light, but that's usually short duration, it's not long. It's like anywhere from 5 minutes to 15 minutes. Some people experience headache after that, some don't. But again, if some people have that since their, age like 20, 30, something like that. But if that is also a new onset experience that you're experiencing, you never had that in your life, although it seems a benign phenomena, but you still should get that evaluated by your primary care doctor or a neurologist to do further investigation. Sometimes, we get MRI for patients, brain MRI for patients who experience this new visual phenomena, such as migraine aura in their life. So we just evaluate that. So that's that something you can bring to your doctor from starting from primary care or your neurologist. And and then here are some of the questions that you mentioned. Three people asked about, so because we had an open-ended question that we asked everyone that, like, is there any specific topic that you want us to discuss? Three people asked about referral to a specialist. So there is a neuro-ophthalmology website, North American Neuro-Ophthalmology Society. So in that website, you can see who is the neuro-ophthalmologist in your area. So you can ask your eye doctors or primary care to refer you if you're experiencing, for example, double vision, to refer you to them. That's one thing to do. And then, unfortunately, there are not so many neuro-ophthalmologists in the US. I think there are about 600 neuro-ophthalmologists all around the US. But again, that's something that you can initiate, or you can ask your doctors to, if you have double vision problem, to refer you to anyone who deals with double vision. And then we'll go over so like, for example, is there any treatment for double vision? We discussed this. And we discussed the muscle issue. Yes, partly is muscle related issue for convergence. And We discussed this as well. Let's go to the next slide. See what I have. Okay, I think we discussed most of this. Impact. So questions are categorized in this way. Um, yeah, definitely many people mention the reading pleasure that is taken away from them because of all this combination of issues. And it's very important. We definitely value the quality of life, the pleasure of reading. So, and I'm sure that to some extent you can resolve that. And about further vision loss, Parkinson by itself doesn't cause, doesn't cause a sudden vision loss, so it's not like that. And again, if anyone experiences like gradually progressive loss of vision, rapid declining vision, those are the kind of thing that is probably not associated with Parkinson itself. So that to say that's reassuring that Parkinson itself doesn't cause that kind of problem. But there are ways to improve vision. And let's see, dry eyes, yeah, morning problem, tearing. Dr. Sorenson mentioned that. And like scratchy eyes, again, those are managed by your optometrist or regular eye doctor. And yeah, meibomian gland dysfunction, also as a cause of dry eye symptoms, again, managed by regular eye doctor. Depth perception problem, judging distance, um, difficulty going down a stair, up a stairs. This is what we discuss, and make sure one thing that you can change is just using single distance glasses for this. And also, if you experience double vision, getting evaluated for that. And yeah, whether or not I'm gonna going blind, no, that's not correct. And one of you asked about, having like lots of other issues, such as like having multiple vitrectomy and eye surgeries for other causes. And some of you also asked about macular degeneration. So again, these are not related directly to Parkinson's. So I can tell you that. So those are completely different, problems. So not directly, although some studies shows patients with Parkinson experience more macular degeneration, or just there is a slightly higher rate of macular degeneration in Parkinson patient versus similar age range people. But again, not a direct uh, causal relationship. And and then okay, so another one, vestibular schwannoma, nystagmus obsulopsia. Okay, so some people experience vestibular problem. Vestibular system is part of the inner ear system. So ears are like the ear system is has two different functions. One is hearing, and the other one is balance. So the vestibular system is responsible for balance. And again, some people have vestibular problem, calcium crystal in the ear, and that kind of sends the signal of balance and position to the brain and to the eye. And sometimes people experience vertigo, room spinning, kind of dizziness related to ears. So that's like a completely separate issue. For that, probably you should see an ENT doctor. Sometimes your general neurologist also can answer that. But again, that's add-on problem for the balance issue. That's from the inner ear position sensor, our balance sensor. And then, so vestibular schwannoma is a kind of growth in the nerve, in the vestibular nerve, that is completely not related to Parkinson. That's just a coincidence. And again, definitely will people with that condition will experience more balance problem. I would recommend, seeing your, again, neurologist, monitoring that also. There are some medication to reduce this, eye nystagmus problem, and also probably your neurologist will know about it. And also balance, physical therapy, vestibular rehabilitation, those are going to be helpful. And this is the other thing that we discussed, that you should, visual aura can be another thing that you should discuss with your neurologist. And then light flashes. So light flashes, if for few seconds, that's not a major concern. But again, obviously, you have to like see your eye doctor at least once to make sure that it's not a retina problem. But if a persistent light flashes lasting several hours, that's that sort of thing that you have to see an eye doctor for it. That can be just from the retina, not related to Parkinson. And yeah, I think. And we can, I think we're like near the end of the time, but I can share with you the like question and answer to all the questions that you discussed, and I will share it with the team here at PMD Alliance, and then you can just go over the detailed question and answer to your questions.
Great. We did have one question that wasn't via the survey. Can you talk about blepharospasm and my eyes close? I can't control them, and it's really impacting my day-to-day life.
Absolutely, absolutely, yes. A few people reported that, but I guess that was like lower in the list. So blepharospasm is when the eyelid muscles start spontaneous twitching and a spasm of the eyelid muscles. And that, yes, that can be very much seen in patients with Parkinson or other type of Parkinsonism, and sometimes in patients with cervical dystonia. What do we do about it? If it is like affecting, if it is in both eyes and affecting your day-to-day activity, causes like eyelid closure, there is a treatment for it, and that's Botox injection. So your movement disorder specialist, your movement disorder neurologist, and sometimes neuro-ophthalmologists also do Botox injection to the tip of your eyelid, to the eyelid muscles, so that it relaxes the eyelid muscles and keep the eye open so that you don't experience eyelid closure. So I think that's definitely treatable.
We had another question from someone who wears contact lenses. They say it's called monovision, where one contact is for near and one contact lens is for far. Would you not recommend that for someone with Parkinson's?
So I would say monovision, many people do that, but when you have originally difficulty with depth perception, so I would say contact lens with monovision doesn't help. So it kind of adds to your depth perception problem. And if that's something that you're experiencing with depth perception, maybe you want to try without monovision contact lens and see how you do.
Squeeze in one last question. I noticed that my eye problems are worse when I'm tired, when I don't get a good night's sleep, or later at night. Is that my imagination, or is there a connection?
No, definitely when that can be, as Dr. Sorensen mentioned, when you don't like sleep well, probably if you're awake more hours, there is more dryness at the surface of the eye. Eye muscles are tired already. You have a lot of eye straining, you know, those are definitely, kind of known. Plus, again, there is a rare condition called myasthenia gravis, which is a fatigue of the eye muscles. Again, not to say coexisting with Parkinson or caused by Parkinson is a completely different thing that causes double vision, fluctuating double vision and eyelid fatigue more toward the end of the day, and there is a like persistent pattern. If like you haven't slept well, by the end of the day, it just kind of gets, more pronounced. Again, that's something to also discuss with your neurologist if there is a pattern to it. But if it is just blurred vision or difficulty focusing, not much of a double vision, I think that's not a red flag, and it's definitely with less sleep, more dryness that can be caused by that.
Okay, well, thank you so much. And as Dr. Miri said, we'll have the slides and the recording ready if anyone wants to refer to that. So thank you, Dr. Sorensen, Dr. Miri, for joining us. Learned a lot and appreciate you really tailoring it to what folks wanted to learn about. And we've all been staring at our screens for more than 20 minutes, so we should go look 20 feet away and take a break and get that healthy eye blinking going. Okay. Well, thank you all. Have a wonderful day, and we'll see you at another PMD Alliance learning session soon. All right. Bye, everyone. Thank you.
Thank
Bye.
you.